All right, we're live. Hello, everyone. Hello. We're going to be starting in just a few minutes.
You do on Zoom too?
This is on social media. So on Instagram and Facebook and YouTube. So this will be recorded for watching after. So anyone who can't be here in person can just watch. I'm going to start maybe in 2 minutes. And I give people some time to join us. Okay. Let's see. Okay, telling more people to join. Let's see. Hello, Pilates-Based Florida. I'm just getting everyone linked in. We're going to start in about 1 minute. Hello. Okay. Okay. We're going to get started. So we might have some latecomers, but I see that some people are already joining us virtually. So for those who were with us for the first one, you know that this is the second lecture that we are doing. My name is Dr. Melanie Carminati. I am a doctor of physical therapy and the owner of Inspira Physical Therapy and Pilates. So we are located here in Park Slope, Brooklyn on 5th Avenue in between Union and President Street. And we are more of a specialized physical therapy office. We see patients one-on-one for a full hour. And we do different specialized services such as pelvic floor physical therapy, advanced orthopedics, craniosacral therapy, visceral manipulation, and Pilates exercise integration. So we have all Pilates exercises in our office. So if there are questions throughout, I'm just going to answer them at the end. Feel free to put questions in the comments. I will do my best to answer all the questions. But I want to just give you a lay of the land too for what to expect for today's lecture. So I'm going to be speaking about pelvic pain today. Pelvic pain can be caused by many different things. I'm going to briefly touch on a handful of things and then talk about some of the pathology and what treatments may be helpful. I'll speak about pelvic floor physical therapy. This lecture is more informal, so I do run workshops as well that are much more in depth. So if you are someone who's watching this and afterwards you just want more information, maybe you want more anatomy images, you want me to break down muscles in the pelvic floor, or maybe you want to know Pilates exercises that are appropriate for certain conditions. I have workshops that we have run in the past that have been recorded that are available for purchase, and then you get the PowerPoint, PDF, and all that stuff, and I am very open for questions after you watch that. So before we get started, I just want to say that this topic specifically, this diagnosis, pelvic pain, we see a lot of individuals, men and women, with pelvic pain here in this office. and it is becoming more spoken about. So I'm hoping that with this lecture, we can just open up the conversation amongst loved ones or clients, colleagues, patients, whoever you're working with, and just share information. So I'm speaking to you today as a doctor of physical therapy, but also as a human in this community. And I really hope that we can just share the information and spread knowledge so everyone can become that much more well. So before we go through the different causes, I want to just talk about pain itself. I have on our YouTube channel a mini pain science lecture. I'm not going to go into the full pain science lecture, but just so we have an understanding, in this office and many skilled practitioners, physicians, physical therapists, when we are helping individuals who are coming in with pain as a primary complaint, we're looking at it from a trifecta, from 3 different categories. We're looking at it from a biological standpoint, a psychological standpoint, and a sociological standpoint. There's something known as the Biopsychosocial Model, and that's taught heavily in physical therapy higher trainings. And it is extremely helpful in understanding the pain experience and knowing how to treat it effectively. So when we're talking about pain today, just know that there's many things that can be causing pain, but we always need to consider biological, psychological, and sociological impacts and factors that could be creating or causing some of this pain. So for a reference, something that I always refer to for my patients is a wonderful book called Explain Pain. I'm going to pass it around too. So Explain Pain by David Butler and Lorimer Mosley. This is an amazing resource for those who are virtual. I highly recommend it. It took me a long time to find a book that I liked for education on pain science, and this one is beautifully done, and the illustrations are really great. So I have no relation to this to these authors. I'm just sharing as a resource for everyone for learning. So Explain Pain. This is a great book if you want to learn more about pain science. So for some of the musculoskeletal causes of pelvic pain, as a pelvic floor physical therapist, myself and the other physical therapists who work here in this office, we all are dual trained in orthopedics and pelvic floor. And when we are treating patients with pelvic pain, they're coming in, we're looking at them holistically. We're looking at them system-wise, like posture, body mechanics. And then when we're getting into the pelvic floor specific assessment, which we would start first with just a general observation. This is done with consent. We are very trauma informed in our office, so we are always having a long conversation and making sure that the patient is comfortable with whatever's happening. But when we get to the internal, or should I say the pelvic floor specific assessment, we are first just observing the muscles. The patient will be wearing a gown, clothes removed below the waist, and we're just watching actually first for breathing. Because what I spoke about in the last lecture was that our pelvic floor follows the movement, a healthy pelvic floor follows the movement of our diaphragm. So as you're inhaling and the diaphragm is descending, so is the pelvic floor. And as you're exhaling, there's a slight movement upward in the pelvic floor following that diaphragm. So your diaphragm is dropping down, allowing for air to come in through the lungs. And then as you're exhaling, letting all of that excess out, the CO2 out, pelvic floor is coming up with the diaphragm. So that's what we're first just watching. If you were to imagine someone laying on their back with their knees bent, we're just looking at the end of the table by their feet to see, is there any movement just with breathing? And then from there, we will cue them through different pelvic floor, either relaxation or contraction as an assessment. And when we get to the internal assessment, which would be with a gloved hand, I'm just going to pass around and show a quick photo. These photos are from Pelvic Guru, an amazing resource for imaging. So this image down here, you can see with the gloved hand, you can see that therapist is inserting a finger to do muscle assessment. I'm going to pass this around over here. Hello, welcome.
Thank you.
So this is just an image of pelvic floor internal assessment. So when we're doing that internal assessment, I'm going to use my model here. When we're doing the internal assessment, I'm just going to remove the first layer of muscles. That wouldn't normally happen. With a gloved hand, we're just going in to feel different muscle tension patterns. So when we're looking at pelvic pain from a musculoskeletal standpoint, this would be one of the assessment tools that we use by palpating to feel, okay, I'm on the ischiocavernosus, that's a muscle in the pelvic floor. I'm on the ischiocavernosus, this feels tight to me, and we're communicating with the patient. The patient's like, yeah, that's where my pain is. And so then we'll go through layer by layer. There's 3 layers in our pelvic floor. I removed the first layer. There's 3 layers in our pelvic floor, so this is the first layer. Then we're getting into the second layer. Second layer is more urogenital muscles that control the urethra, compressor urethrae, things like that. And then the third layer is much deeper muscles, such that would potentially be causing pain too. So we'll be palpating around, just checking different muscles at different layers to see, is this muscle tight? And then communicating with the patient. And so then from there, after the full evaluation and assessment, we would then move forward with treatment. And we have a few massage therapists here with us. So any massage therapists who might be listening, in physical therapy, we use different manual therapy techniques. It's some of the same kind of techniques, might be trigger point release. If we feel a trigger point in one of the muscles, we could be doing internal trigger point release. Might just be some transverse friction. There's also a myriad and number of different manual techniques that we can do to release muscular tension in the pelvic floor. But really the key is being able to diagnose and be specific about what muscle might be causing the pain. So I'm talking now just about musculoskeletal pelvic floor assessment. This is something that could be causing pain. It's known as hypertonic, or AKA very tight musculature in the pelvic floor. I want to also mention that there's pelvic floor muscles, but there's also pelvic wall muscles. We have the obturator internus muscle. This muscle is a very deep muscle, and it's a muscle that creates the wall as well as the piriformis. So these muscles can be causing pain as well. So through the pelvic floor assessment, we would determine, okay, is it actually coming from pelvic floor muscles? Is it coming from pelvic wall muscles? Now, since I mentioned the pelvic wall muscles, I should say that sometimes those pelvic wall muscles might, symptom-wise, feel like hip pain. So sometimes patients, in our office, we see a lot of patients with just complex orthopedic things going on who haven't gotten better with traditional physical therapy, and they need more like specialized assessment and care. And sometimes patients will come in with hip pain, like deep hip pain, or they experience dyspareunia, which is pain with intercourse either during or after. And we can go through the differential diagnosis and be like, oh, okay, so you're getting this hip pain, and with the assessment, we can pinpoint, okay, it's actually one of the pelvic wall muscles that's tight or in spasm because of X, Y, and Z, and then treat appropriately. So those are 2 things for musculoskeletal. There's also considerations for the lumbar spine. So our lumbar spine, depending on what's going on, maybe one of the lower segments of the discs, this could refer into the hip groin area too. So you could have symptoms coming from the lumbar spine that's someone might be feeling, oh, I have pelvic pain, but through the assessment, we're able to differentiate, okay, because everyone here, all the physical therapists, we would do a full assessment and we would see, okay, this actually seems like it's coming more from the spine than actually from the musculature. I realize that sometimes I speak very quickly, and so I promise I'm going to answer questions at the end, but I want to give you guys as much information as possible. This is recorded, so you can go back and watch it. Some other musculoskeletal things to think about when it comes to pelvic pain. So the pelvic floor musculature is innervated by the pudendal nerve, and I'm actually going to want that back in just a minute. So the pudendal nerve has many branches, and if you think of where your underwear covers, it's like little spider or like little threads on either side pointing outward from the pelvic opening. Okay, so this is a nice image of one side of some of the pudendal nerve branches. Again, pelvic guru images. I'll pass this around. So you can see some of the nerves there. Now, pudendal neuralgia is a term for inflammation in those nerves that could be causing pelvic pain. One of the common mechanisms of injury of the pelvic nerves, the pudendal nerve, can be hypertonic pelvic floor, actually. So you can have muscles that are compressing and causing restriction in the nerve that might be causing the person to present with different pain symptoms in this area. Another mechanical thing to think about is people who ride bikes. So people who ride bikes, cyclists, where does the seat press? It presses right into that area where those nerves are. Now, when we are doing assessment, again, it's not just internal. We also do external palpation just to feel, to see, okay, there's this area known as the Ischiorectal Fossa, or they use fascia and fossa interchangeably in anatomy in the pelvic floor. So there's this collection of fascia down here that can kind of be tight if that's the symptom that they're experiencing pain in that general area. And so we'll just palpate and see, okay, is this where one of the pudendal nerve branches is located? And with treatment, everything would be comprehensive. So we're not just doing manual therapy. There is a lot of neuromuscular re-education. So like relearning how to stand, relearning how to sit, so that you don't continue the thing that is causing the pain to happen. In regards to sitting, one of the other musculoskeletal, and I think this is the last one I was going to mention, one of the last or the other musculoskeletal things to consider for pelvic pain is coccydynia. Coccydynia, aka inflammation in your coccyx, your tailbone. So in our spine, this is just the last two segments of your lumbar spine. Then you have your sacrum and your coccyx. So everyone's anatomy is a little bit different, and the coccyx can be positioned in slight tilts in other either anterior, posterior, or even lateral. So everyone's anatomy is different. Because this is an extension of the spine, a lot of that can be influenced by maybe if they have scoliosis and they have a tendency, or their curvature has them fall to the left with the convexity in the lumbar spine, and that affects the whole curvature down below in their sacrum and their coccyx. But also, if you've ever fallen on your tailbone or you sit on a hard chair, all of these things over time could impact the position of your coccyx. Some people have subluxed coccyx bones. So this most commonly happens after a fall, like if you slip down the stairs and you just land on your tailbone, but not always. All these things I'm talking about, these are possibilities. It's not a definite that if you fall on the stairs, your coccyx is going to sublux. But someone who's coming with pelvic pain, if they are mentioning more rectal glute kind of pain symptoms, and there's no history of gastrointestinal conditions or autoimmune conditions that maybe would cause inflammation in the rectum, then we would be assessing the coccyx. For the coccyx, there's a lot you can do externally from a soft tissue standpoint from manual therapy. And then there is some techniques you can do internally to reposition the coccyx, to mobilize the coccyx, and then some other taping techniques you can do to stabilize. One of the common causes, though, I should say, of coccydynia, if it's not subluxation or trauma related, is just prolonged sitting. So if you're sitting on a surface and your anatomy is such that your coccyx is coming in contact with the surface that you're sitting on, and it's hard, and you're not moving, and you're really sitting there the whole time, months, years of doing that can just cause inflammation. So there are some specific coccyx cushions that I do recommend to my patients, but it depends on their anatomy, because some of them position the pelvis more in an anterior tilt or posterior tilt, and so it's always best to get a consult for that, so your therapist, the physical therapist, can figure out, okay, which cushion is best for you. And all it does is it just lifts up your pelvis so there's no contact with the coccyx, so that it can heal. Okay, so those are the musculoskeletal causes of pelvic pain that I wanted to mention. I'm going to go into some other causes of pelvic pain. These are for individuals who have female anatomy, female reproductive anatomy. And the first one I want to mention is PCOS, Polycystic Ovarian Syndrome. So our ovaries are down here, okay? Uterus is in the center, fallopian tubes connecting. If someone has a cyst on, or multiple cysts on one or both of their ovaries, they could have pain getting referred into the pelvic floor. So if they've also had a cyst that's burst, they still could have scar tissue in that area that is then referring into the pelvic floor as well. Another condition that has become much more well-known, but still is very mysterious in cause, is endometriosis. And so endometriosis is a condition where endometrial-like tissue, not endometrial tissue. I realize that that recent research has said that it's not always endometrial tissue, but endometrial-like tissue can be dispersed in places outside of the endometrium, so outside of the uterus. So you can have endometrial tissue in your bowel, in your sigmoid colon, in your rectum, diaphragm even, and it's very insidious. You know, they're doing a lot of research on this diagnosis because it is way more prevalent than it used to be, and this can cause pelvic pain. So they can also have abdominal pain. When we talk about pelvic pain in general, we are considering the abdomen as well. So for physical therapy for pelvic pain, we always assess the abdomen too, because you could have muscular tension or you could have some of this organ stuff going on. For those specific conditions, PCOS, endometriosis, myself and the other PTs in this office, we use visceral manipulation. This is really helpful for PCOS, definitely. For the endometrial individuals with endometriosis, more so for those with early stage endometriosis with smaller lesions, or adhesions of the tissue. And visceral manipulation is osteopathic. It's an osteopathic technique. It's very gentle, hands-on. It's all about specificity of where you're placing the hands, and it's not a lot of force. I know the name visceral manipulation kind of sounds like it might be intense or like high velocity, but it's very gentle, and it requires the therapist to have hands that can listen and feel through tissue. So I can say for myself, when I was trained in visceral manipulation like 7 or 8 years ago, this was after I myself had a cyst burst on my left ovary. And it happened a few years before I started getting trained in it. And it wasn't until after I went for continuing ed courses for physical therapy, sometimes are 3 days, 4 days. And this specific course through Baral, when I went for the first training, I had no pain afterwards, but I wasn't aware prior to any of the visceral manipulation that I was having any referral from this area into my pelvic floor. So I can say from a personal standpoint that visceral manipulation is tremendously helpful when it's done with a skilled practitioner for relieving potential causes of discomfort from endometriosis and PCOS related conditions. Okay, moving into more gastrointestinal. So in endometriosis and PCOS as well, sometimes there's that gastrointestinal symptomology that pairs with them. For pelvic pain specifically, if you have constipation, if you have IBS, if you have other autoimmune conditions like Crohn's disease, colitis, this will cause obvious inflammation in the abdominal cavity, but it can refer into the pelvis too. And so depending on the individual, obviously not when they're in a flare, most people who are coming to us have some kind of medicinal medication that they're taking from their gastroenterologist who's helping them manage Crohn's, colitis, or other things like that. But the visceral manipulation is tremendously helpful for that as well. I want to mention too that craniosacral therapy, although it does not work directly on the area, getting the central nervous system to come out of a sympathetic overdrive and more into parasympathetic in general is just helpful for any kind of pain. So sometimes if I have individuals who are coming for persistent pain, if it's not pelvic pain, I will use craniosacral therapy first to allow for the central nervous system to come into parasympathetic so that we can break that sympathetic overdrive that sometimes happens. When someone has been in a persistent pain state, many times their central nervous system is just always on, fight or flight, like always on high. So getting them to transition into parasympathetic is really crucial for healing. Okay, so I mentioned pudendal neuralgia already. I want to mention one other bladder condition known as interstitial cystitis Ic. Used to be known as painful bladder syndrome. And so as you can imagine, because our bladder is down here, if you have inflammation in the bladder or thickening in the wall, this can refer into that area too. So I mentioned in the beginning that the biopsychosocial model is crucial to be used by the practitioner and the patient for treatment of any kind of pain. And there are times where someone may go through an emotional trauma or just extreme stress, and that might manifest in somaticized pain in the pelvic floor. I have a podcast, it's known as the Know and Do Better podcast, and I interview different physicians and psychologists and wellness practitioners. And a podcast that I did a few months ago, I interviewed a psychologist, Dr. Kim Fishback, and we just spoke about emotions in our physical bodies. And she had mentioned an example where she had a patient who was coming in for psychotherapy, who was having pelvic pain, and it was actually surrounding some relationship issues that were going on. So some of the stresses in the relationship. So remembering that we are one person, one body, and that there is the mind-body connection, and we need to consider all factors is really crucial. Okay, so I want to mention some other treatments for pelvic pain. So I've mainly spoken about pelvic floor physical therapy. That's obviously what I am specialized in to speak about, but there are other treatments, right? So when patients are coming into the office, for the first 30 days, I'm not sure if everyone knows this, but in New York State, you can come to a skilled practitioner, aka someone who's been a physical therapist for more than 3 years, who has 1,500 hours or something, without a prescription. So patients can come to us for physical therapy without a prescription for the first 30 days or 10 visits, whichever comes first. So many times, if a patient is coming to me in the first 1 or 2 sessions, if they're coming for pelvic pain, I many times will refer them to a pelvic pain physiatrist. It can also work in the opposite way, where there's a few pelvic pain physiatrists, such as Dr. Ahmed at Pelvic Rehabilitation Medicine, Dr. Christian Reuters as well. He works with male pelvic pain patients. They will refer patients here, so it can go both ways. But it's really nice to remember that physiatry or physical medicine is a nice conservative treatment as well. They do some procedures like injections, nerve blocks. They can also prescribe different suppositories that help, like Valium suppositories that can go into the vaginal opening or rectal opening to help with relaxation in the musculature. And so there are other realms of treatment. If you are an individual with female anatomy, you may have been speaking to this with your OBGYN or specialist or your urogynecologist. So there's other practitioners who help with pelvic pain. I'm obviously mainly speaking about pelvic floor physical therapy because that's what I do. I wanted to mention too that for musculoskeletal, there we go. It came back to me. The thought came back. Okay. For pelvic pain that's more musculoskeletal in nature, I'm going to go a little bit more specific. So if someone with female anatomy is having clitoral pain, this can be many times from muscle tightness, but also just from tissue tightness. So they could have just tissue tightness through the perineal area, and some perineal massage may potentially help. Other types of specific pain, you could have painful orgasms. Other pelvic pain, you could have pain with urination, pain with bowel movements. So there's many other things too to consider there when we are dealing with pelvic pain. And so when people come in for pelvic floor physical therapy, we obviously talk a lot first, and the conversation can go into many different directions. So we talk about generally when the symptoms happen, what causes the symptoms to be exacerbated or aggravated, what makes them feel better. And then we'll talk about bowel movements, we talk about urination, we talk about any sexual activity, we talk about physical activity. So there's that. And I'm remembering now that I also want to mention post-operative or trauma. So for women who have had vaginal deliveries, if there has been any perineal tearing and there's scar tissue in that perineal area, this could be causing pain. This especially could be causing pain with intercourse, aka dyspareunia. You could have pain immediately with penetration. So that's something too that we could do scar-specific mobilization. And other traumas. So yeah, I already mentioned coccydynia. Yes, okay, so that's that. So with everything that we just spoke about, those are all potential causes of pelvic pain. How we would move forward in pelvic floor physical therapy, we would start first, depending on the person, possibly with craniosacral therapy, definitely with some hands-on. We're not always doing internal work. The internal muscle release or tissue release, internal or external, is just a portion of the treatment. We are going through different exercises as well because general mobility, pelvic tilts, spinal mobility, depending on what's happening, can be appropriate as well. If we are working with someone who has hypertonic pelvic floor or tight musculature in the pelvic floor, you want to think about what muscles attach onto your pelvis. So we have our adductors, our inner thigh muscles, we have the hamstrings. You also want to think about the hip flexors. You want to think about some of the deep abdominal muscles as well. We have the psoas, we have the iliacus. All of these muscles we're considering also. So after that, we may potentially do some Pilates-based exercises. And so Pilates is amazing because it's mind-body. I explain it as a mindful movement method, and you really have to connect. One of the first principles of Pilates is actually breath. So breathing helps. Diaphragm breathing specifically helps to transition into that parasympathetic nervous system. So someone who's having pain, getting them to transition, as I mentioned, out of the sympathetic overdrive into parasympathetic can be facilitated via diaphragmatic breathing. And there's many ways to do the breathing, but we will start with breathing. We'll start with pelvic awareness, posture, possibly some stretching. But when we are progressing in physical therapy, because physical therapy is progressive, we start with some foundational exercises and treatments, and the goal is to progress and build. Obviously, rehab is a journey, and it's not always a direct line. Sometimes there's ups and downs, but the goal is to, if it's hypertonic, to release the muscular tension and then retrain proper pelvic floor muscle activity. There's a special population that I want to mention because I was a dancer before I became a Pilates teacher, before I became a physical therapist. And in ballet training, and some modern training as well, but specifically in ballet training, you're trained to lift in and up, right? And so you're getting that muscle activity from the pelvic floor, from the adductors, from your abdominals, and myself included, many times we'll continue to walk around with that up kind of muscle engagement. So what happens then is that your pelvic floor musculature is always engaged. And so with that, the muscle won't be healthy because a healthy muscle is one that can lengthen fully, relax fully, and contract. If you're always engaging, this can actually cause the musculature to become short and then weak, potentially painful, but weak. So dancers, let it go. Think of, if you are an individual with female anatomy or male anatomy, if you think of a flower opening in that perineal area, give yourself and the pelvic floor a break to just open, be relaxed, let your abdomen be soft, breathe, do that belly breathing. Really important to just let that abdominal wall and pelvic floor musculature be relaxed, because that could potentially cause other dysfunctions down the road. I want to also just give the lay of the land for pelvic floor physical therapy, because this is something that I just learned recently. One of my dear friends actually was having pelvic pain, and she doesn't live in this area. And I said, you have to see a pelvic floor physical therapist. They're going to help. It's going to be good. And so she called her insurance and found a place that was in network. And I was talking to her, and she's like, it's not getting better. It's not getting better. And I'm like, I know her symptoms because she told me. And I'm like, what's going on? Why is this not getting better? And she's like, well, the therapist spends 10 or 15 minutes with me. And I was like, I said, did you go in network? She's like, yeah. And so unfortunately, the way physical therapy and network works is many times they book multiple patients in an hour. And I didn't think that they did this for pelvic floor PT, but different businesses run differently. And so she wasn't able to really make progress, because if you only spend 15 minutes, if you think about it, for any kind of therapy, psychotherapy, massage therapy, physical therapy. If you have 15 minutes with a practitioner, how much change can you cause? How much, positive change can you cause in the tissue or the person's body awareness? And unfortunately, it's not a lot. So I want to also say that co-pays for in-network physical therapy range like $50 to $60, and many times you have to go multiple times a week. Well, here at Inspira and other practices, we don't work with insurance directly, but it actually ends up being more affordable and it costs you less to come to a place like this because we give you higher quality care because we spend the whole time with you and we're able to progress you quicker. We're also super flexible. Typically, patients come twice a week in the beginning, but then once a week, and then once every other week, and then once every 3 weeks, and then once as needed. So if you are someone, I highly encourage, it's going to be higher quality if you go somewhere that is out of network, that spends the full hour with you, because then you're going to be able to get better that much quicker. So FYI, about the lay of the land for pelvic floor PT. So that was about all that I wanted to say. I want to just mention a few things about Inspira before we answer questions. So you know that we're a specialized physical therapy office. We do advanced orthopedics and pelvic floor, men and women. We have Pilates private lessons that happen here. We also have virtual Pilates, Tuesday and Thursday, 11 a.m. The first class is free. So if you're tuning in right now and you want to take a virtual Pilates class this Tuesday or Thursday, just send us an email or DM me or leave a comment with your email and we'll follow up and we'll sign you up. And I do these lectures intermittently. Like I said, this is more informal and it's just educational and resource based. But if you are a Pilates practitioner or just a practitioner who wants to dive deeper, we have the workshops. And I think I already mentioned my podcast, Know and Do Better. It's available on Spotify, YouTube, Apple Podcasts. You can listen to different podcast interviews that I've done with different practitioners as another resource just to learn more. So I'm just going to pop onto our different mediums here and take a look at some of the questions that we have. Oh, okay. Hi. Okay, that's not a question. They can't wait to do a session. Great. Can't wait. Okay. 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 Okay, we're going to message you. Hello, hello, hello. Thank you for joining. Okay. And then I'm just going to look in the comments here. Anyone on YouTube, Facebook have questions? Okay, I don't see any comments there with questions. Okay. Any questions for people who are here live? It can be specific, it can be general, it can be, I don't know, you're not sure.
Not for now.
Not for now.
I think I have prenatal women who come
Prenatal. Okay, good. I didn't mention that. I can talk about it.
I have pelvic floor pain.
Yes.
And then they say, oh, I have I went to PT.
Okay.
Do a trigger points. I don't know what this trigger point over there. How you guys do it for? What we supposed to help them in the kind of pain.
Right.
Even pregnancy women.
Right. Okay. So we're talking about prenatal individuals who are having pelvic pain. So this is good. Thank you for bringing this up. There's a few considerations for pelvic pain for prenatal. So a few common things that can happen, especially towards the end of the pregnancy, round ligament pain. So that could just be a referral right about here from the ligament that's being stretched just from the uterus expanding. You could also have pubic symphysis dysfunction, where because when you're pregnant, there's another hormone called prolactin that's floating around in your body. It makes all the ligaments lax. That could just be causing a separation. So there's that. But if it is actually pelvic floor, depending on what muscles, sometimes they could just be tightening up because of all the pressure, right? So all the pressure going down from the uterus, the baby growing, muscles could just be tightening possibly. For trigger point internal work, we would just see internally, okay, which muscle is it? Then we would just do the specific trigger point muscle release. It's no different than any kind of trigger point release that you would do. It's just specific for the muscle.
It's not something we're allowed to do.
Of course, yeah.
Physical therapists are not
Right,
allowed to do
yeah.
that at all.
Yeah.
In America, at least.
Yeah,
It's not something we
Only
can do.
physical therapists do it, actually.
Yeah.
There maybe are some physiatrists, but honestly, the physiatrists will refer to physical therapists to do it. Yeah. So, yeah, if they said that they had trigger point release, then they went to a pelvic floor physical therapist for it. Also, I'm glad you brought up prenatal because I didn't even mention that. But when you're thinking about that laxity, they could be having SI joint, low back, sacrum. So getting an SI belt is really helpful because it's just the nature of being pregnant. The ligaments are more lax because of the hormone. Yes. Does that answer your question?
Okay. Just get the idea what is around what is the cause of pain
Any other questions?
That's my main thing concern about what I see prenatals that they always have pelvic pain. That's what we see a lot.
Yeah. Absolutely, yeah. And it just makes sense because if you think of the, commonly what you see with pregnant individuals is that anterior tilt, which just puts more pressure downward. So all of the structures around there are just working over time. Did you have a question?
Yeah, what kind of treatment would you recommend for somebody with a dangling fibroid, roughly about the size of a cantaloupe, that has trouble doing abdominal exercises, number one, as well as, I guess you would call it stress urinary incontinence?
Okay.
That's my own diagnosis, it's not
Okay.
somebody else,
Okay.
someone's diagnosis. What kind of treatment would you recommend?
So someone with a fibroid. So if they already know they have a fibroid, they've already seen a doctor for it.
The GYN.
GYN, yep. So for someone with a fibroid, we would probably do visceral. I'm gonna wait because I hear the dog outside yelling or yelping. So we would probably do some visceral manipulation for surrounding tissues. So we would do some visceral manipulation in the abdominal pelvic area. We would potentially see if there's also hypertonicity in the pelvic floor. So it would all be based on what we find in the assessment. So someone who has fibroid pain would benefit from visceral manipulation, pelvic abdominal organ, even just general soft tissue work through the abdominal wall, and then some pelvic specific exercises. So if someone's having stress urinary incontinence, that typically is more of the pressure system. I spoke about this in the last lecture I did 2 weekends ago. It's recorded on our YouTube, so you can listen in on the recording. But for stress urinary incontinence, right, it's only happening when the body's being stressed. So when you're sneezing, when you're jumping, when you're laughing,
From laying
moving,
down to standing up.
position, exactly. So what happens, this is another thing, so position changes, even just sitting to standing is a common thing that can happen for stress incontinence, urinary incontinence. And we go through a whole education of breathing, core engagement, pelvic floor engagement, because commonly what happens there is that there's a release or a let go in one of the muscles that makes up your core. So your pelvic floor is actually part of your core. You have your pelvic floor, you have your deep transverse, you have your lumbar multifidi, some of the back muscles, and your diaphragm. All four of those muscles, it's like a soda can. They work to keep the pressure stabilized. So you have that front wall of the soda can, the back wall, the top, the bottom. If you pop the top of the soda can, the pressure releases, right? So the pressure is maintained when all those walls are working together. So that's something we would work progressively through to understand how to engage and strengthen some of the muscles, because commonly it's just a coordination and a weakness thing. But specific for the pain, visceral manipulation would help tremendously for the pain specific for that. Did that answer your question? So
Yes, for the most part, it's just that the pain is only experienced when trying to do abdominal work, like
I see.
traditional abdominal exercises,
Uh-huh.
if you pop it in a DVD or something,
Right.
and you're trying to, at some point, an intense cramping.
Yeah.
And
Got it.
when that happens, the only thing I can do is just lie there.
Great. So, sorry, not great that that's happening, but I'm glad that you clarified that. So, with the exercises that we do here, we go through a progression. It's Pilates-based, and we start with neutral spine exercises. So, you would never be doing a crunch right away. We would start with simple exercises on your back, being able to engage with just lifting a leg, being able to engage with just moving your arm, being able to isolate and control in certain positions relative to gravity before like a crunch is very advanced and it's like very end range, before you move even into a chest lift or move into any kind of spinal mobility. So we start first with some neutral spine exercises, being able to really isolate, have these simple movements be done with the engagement first, and see if just with that there's still the pain being experienced, then we would need to do more hands-on before we do the exercises. So sometimes, many times, I didn't mention fibroids, so I'm glad that you're mentioning that. I mentioned PCOS and endometriosis, but we also have fibroids to consider too. These things can be causing pelvic abdominal pain. So many times, if there's adhesions that are still there, any kind of scar tissue, you might need to work through the surrounding tissue first in order for you to be able to get and progress in abdominal strengthening. Yeah.
Okay, so
Yeah.
the recommendation would be to come here versus seeing, I don't know, there was some kind of specialized doctor you were talking about.
Oh, physiatrist. Physiatrist. So it could go either way, honestly. What I will tell you is that the physiatrists always refer to physical therapy. So you could start with physical therapy first and see, but we would have the conversation, okay, we know this is going on. We could potentially want to refer you to physiatrist, but we might not need to do it right away.
Thank you.
Yeah, of course. I'm just gonna hop on here and take a look again. Okay, any questions? I know I covered a lot. Okay, any other questions? I'm here, so. No,
I'm good.
you're good.
Yeah, only my thighs are prenatal, so I just want to hear you what is this, this is
Yeah.
really good.
Yeah.
Sure.
Okay. All right. So with no further questions, I'm just going to end the broadcast. Thank you all.